Hello everyone, my name is Mehdi Rahimi and I'm an endodontist that works out of Sydney in a group practice. We service areas such as North Shore, Chatswood, the West, Parramatta and also the East, Double Bay. And it's an honour to be giving this lecture to the divisions and study group, and I think it's the new norm, giving lectures via this particular way during these difficult and unpredictable periods, the COVID-19 era. And I really wanted to cover and touch on a topic that's been actually a passion of mine since I've been going through postgrad training. It's trauma, and really I wanted to cover the immediate management because that's appropriate for the guidelines and the restrictions we have, the level 3 restrictions, the current restrictions. And so we are going to be seeing the true emergencies, and the true emergencies, one of the categories is obviously trauma. So a lot of what I'm about to cover, we would have spent 6 months during postgrad learning. So I'm really going to give you a crash course on it in the next sort of half an hour or so. So first thing I'd like to touch on is if you encounter a trauma, it's a bit too late to go and read textbooks or find out what to do exactly, and it's better to have a nice planned way, and part of that plan is to go through guidelines. The guidelines are at the IADT, dentaltrauma.org site, and sometimes when you see a case like this, you may have a few hours before the extrusive luxation injury has a lesser outcome. The prognosis drops quite dramatically, so you've got to reposition it fairly quickly. And you might have 30 minutes, maybe 45 minutes before the avulsion injury has a lower outcome. So therefore, you're not going to, the guidelines are a guideline. It doesn't mean that every single case you see is going to abide by the guideline, but it does mean that according, to the literature, there's a better success rate, less complication rate. So I recommend the mobile app, and I've got it on my own mobile, because this mobile app you can also recommend to teachers. If a kid comes in and they've got a problem behavior, they're more likely to have trauma, or they've got increased overjet. You give that sort of guidelines so teachers at school can quickly place a tooth back in an avulsion injury rather than wait till they get to a dental office many hours away. And during these times, it's important you recommend it to all patients. The other thing is, guidelines, again, there's some literature suggests if you conform by the guideline, there's a 12% complication rate compared to 40-50% complication rate if you don't abide by the guideline. One thing I'd like to address is which teeth are the most common, and most often you'll see the central incisor or the lateral incisors. However, do not forget to take a radiograph of a lower incisor, because in 1 to 2 out of 10 cases when you see a trauma, there's a lower incisor involvement. And this is a courtesy of Dr. Asker Sergeson. He saw this patient and he took this radiograph, and that's an old trauma. You can tell blunting of the fracture line, calcification of the coronal part of the this crown. I mean, maybe if the trauma was diagnosed when the trauma actually occurred to this tooth, maybe the situation would have been different. But again, important to take a radiograph. I like to go through the diagnostic sieve that I have when I see a trauma case. And if you want more information about that, read chapter 9 of the Andreasen textbook, the 2014 edition. And this particular textbook is interesting because the Scandinavians were seeing a lot of trauma in the hospital. They did a lot of research on it. Jens Andreasen used to be married to Frans Andreasen, and Lars is the cousin. So it's the Bible, really, of dental trauma, and I highly recommend it. It's a really easy read in a lot of cases. And in that particular textbook, you go through this particular diagnostic sieve. So you start with fact-finding. Another must-read paper is the older version in 1985 was published by the Andreasen group, and then Frans and Bill Kaler from Australia published this paper, which is a revision of standardizing your documentation. So here's the clinical exam sheet that you'll go through tooth per tooth, and it gives you, you can write exactly what you see at the baseline when you see the tooth and when you see the tooth around about 3-6 months later. And again, standardizing means take photographs and take as many radiographs from different angles as you can. This is where you don't go by the principle of as low as possible. You do take documents well, you do radiographs with shift angles because it will give you more information, and we'll cover cone beam CT very shortly. One of the most important parts about fact-finding after you see the patient is to go through a neurological assessment, because while the patient's sitting there as you're asking them questions, within a few minutes, you might notice that the patient is confused. They may have slurred speech. They may have, changes in mood. They may be confused. So with patients with headaches and things like that, epicranial hemorrhage within a few minutes, can change the patient's life, because we know that a brain injury is certainly more important than treating the teeth. So therefore, if you see that, you should refer to the hospital ASAP, because sometimes you don't pick the patient and you can't realize how severe that injury is until with time things can develop. Apart from that, the fact-finding part, the most important fact-finding is when the injury occurred. So we need to know the timeline. Again, I touched on that. If it's an avulsion injury, we need to know it's more than 60 minutes or less than 60 minutes. So we need to know what treatment to perform accordingly. Where did the injury occur? Because we need to know if it was in a contaminated area or was it in a clean region. So again, tetanus, being up to date is important. And you just need to know where and how. How did the injury occur? Because you've got blunt trauma, you've got sharp trauma, and sometimes with some types of trauma, there's more chance that there's underlying trauma, such as jaw fractures and things like that as well. So you need to investigate further. Was the treatment elsewhere, and was there a previous dental injury? Because you don't want to be there, in an emergency situation, and we call it true emergency, and all of a sudden the trauma has occurred many months before. And you also need to check for disturbance in bite, because sometimes disturbance in bite means more serious jaw fractures, mandibular and left fork 1 fractures in particular. And also you ask the patient about thermal changes, are the teeth painful to touch? All of those things you need to record at the time of trauma. One of the most important things is you do your extraoral, intraoral examination, you palpate everything, and take home message from this lecture: examine from outside and treat from inside to outside. Treat the hard tissue before you treat the soft tissue. So extraorally, you might see deviated nasal septum. You might see here swelling and ecchymosis that may be related to an underlying jaw fracture. You also might see, various lacerations of the lip, and you always take a radiograph. A quarter of the standard periapical radiograph you take of an anterior is what you take to see any radiopaque material within the lip. And you might even see teeth where you're not meant to see, like this injury here, where it went actually through the nose, the nasal floor. And with step deformities, this is important, because if there's an anterior open bite or a step deformity, there may be an underlying more serious injury. So with those type of jaw fractures, you need to probably take more further scans of the jaw to find out if there's any other more serious injuries to the skeleton. Now, intraorally, you might see ecchymosis in the floor of the mouth, and this may be indication of a mandibular symphyseal fracture. You might see a full alveolar fracture, and you might see an old trauma, or you might see a new trauma with pulp exposed. Very important to take radiographs, because you want to be able to assess the situation and do the appropriate treatment, but you also want to have a good baseline. And medical legally, you should keep it as records, obviously. Keep a very clear record of them, because some of these trauma cases may later on become medical legal cases. You would always take several angled radiographs of high quality, and they should be reproducible, so you should be using a paralleling device. And the IDT guidelines are: you do a parallel or horizontal view depending on what you're seeing, and then you do a 15-degree shift to mesial or distal, and you always do a horizontal occlusal view. So they're the minimum radiographs you need. Example of how radiograph is important here: there's a shift radiograph of the same area of trauma, and what you're seeing is what might appear as to be a horizontal root fracture, actually with the shift changes, so that's an alveolar fracture. You're ruling out a horizontal root fracture here. Importance of cone beam. Well, according to the guidelines, the American Association and the IDT, wherever you can in trauma cases, especially with crown root fractures, luxation injuries, which is pretty much all the trauma, and intrusion injuries, you should be doing a cone beam CT. of the area. And here's an example here where the dentist came to me in emergency and said, Mehdi, we're going to do a pulpotomy here. Yep, and we're going to do these are uncomplicated crown fractures. We're going to put a restoration over these teeth. And I had a look with my loupes, and I said to the dentist, we need a cone beam. And he was looking at me funny. And the reason for it, because I saw something in the lateral, which was indication of a craze line. You have one look at this, you see the crack is actually equicrestal, subcrestal, and you go back to that other image, and you can't see anything on that lateral here. But all of a sudden with the cone beam, you can see a lot more. So again, cone beam CT, wherever possible, should be taken. I'm not advocating cone beam CT every single case, but many cases in trauma, it has been recommended. In terms of diagnosis, the number one diagnostic tool is obviously the CO2 ice. It's much cooler than endofrost, which is minus 40 degrees. It is a little bit less practical. So these days you may choose to get Endovit or another form. This is an Australian brand, which is minus 55 degrees, or the one from Amalgadent is not bad either. So these are minus 55, they're a little bit cooler. Where do you put the ice? Often you put it in the incisal third of an upper incisor, you put it in the cervical of a molar or premolar, and you're looking at basically a baseline. However, remember that for the first 3 months, you may get a false negative, so you might not get any response at all. So you wouldn't worry, you just have a baseline, but it doesn't mean you should jump in and do treatment just because the tooth is non-responsive to ice. And here's a case where the tooth was non-responsive to ice. Both these teeth were actually inconclusive pulp testing. The dentist referred for further investigation. All I did is review, and about 3 months later, both teeth were responsive to ice. So we call that a transient change. And often the tooth still has vascular supply, even if the neural supply, which is the test we're doing, the cold CO2 test and the EPT test, are really neural tests. They're sensibility tests. They're not a true vitality test. And here's another example, Jeffrey Heathersay. This paper on transient apical breakdown is when you get this internal resorptive area, and that resolves with time, and that's the normal basic remodeling. Dentinoclasts and dentinoblasts are coming in, they're remodeling the inside. So that's just a normal process, and sometimes during this process the tooth may not be responsive. Here's another case where the patient did have quite severe luxation injury. It was a young 7-year-old. I splinted with a semi-rigid splint, and you can see open apices, negative to CO2 meant nothing, because 18 months later, teeth were developing normally and they were responding normal to ice. A true vitality test really is the laser Doppler, and I've heard that the Japanese are coming up with a user-friendly, dentist-friendly laser Doppler, because most of the others are not practical enough. These days, I'm using the pulse oximeter. It's called the Nalcor, and the reason why I use it, because all the oximeters are, designed like, mobile phones, when one thing doesn't fit the other. And really this ear clip is what I want, because the ear clip, and some people use the pediatric, the finger clip, fits the tooth, an incisal or a lateral in an adult quite well. So then you can get a true pulse from that tooth. So this is the true blood supply, because as you know, again, with trauma, neural supply is often the one that's affected, and blood might still be coming to that tooth. So this is where I get it from. I can share that with you if you email me, mehdi@gentoendodontics.com.au. And papers on it, just one paper of many, where they did thermal testing, electric, pulp testing. If the teeth had no response on day 0, around about 94% had actually a positive response at 6 months. Whereas teeth that were tested at day 0 that had a pulse oximetry positive response throughout the study of 6 months still gave a positive response. So again, pulse oximetry a lot more effective. People ask me about tenderness to percussion. Well, at the time of trauma, with the first 2 weeks, obviously the tooth may be sensitive, and that doesn't mean you should jump in and do treatment. But after 2 weeks, there's a lot of evidence to suggest that pulpal necrosis is most likely the reason why the tooth is still tender to percuss. Changes in color doesn't mean you should jump in, because teeth with time can come back to normal color. And so if in doubt, this is a rule, minimum 2 signs or more before you jump in. So you've got to have percussion sensitivity after the 2-week period, plus a negative sensibility test. And if the patient has symptoms, obviously you get into the tooth. So you need 2 or more signs. So again, recap on diagnosis. You have to have a good checklist, standardize your procedure. You examine from outside to inside, but you treat from inside to outside, hard tissue before soft tissue. And you want a pulse oximeter wherever you can get it, or be really wary of a CO2 test at day 1 or an ice test, because it might not be conclusive enough and you shouldn't jump in until you get 2 or more signs. So, and follow-ups are important, of course. So once you've done your assessment, now you're about to treat the tooth, and the aim of treatment really should be focused, especially with young immature roots, to preserve pulp vitality. So with enamel infractions, these are within the enamel. These are little craze lines that might happen after trauma. Most often, no treatment and there's no chance of the tooth, because the pulp is very resilient, becoming necrotic. And I guess if you're going to do any treatment, it's because they might be a little bit sensitive to cold or cold air. So Robert Love and others recommend etch bond, put a little bit of adhesive over the top of the craze line, and that usually settles the tooth down over the period while the dentine recovers and is naturally able to cope with the cold sensitivity. In terms of uncomplicated crown fractures, hardly ever do they become pulp necrosis. I like to caution you that if there is a deep uncomplicated crown fracture, and this is your clinical judgment of that pink hue, if you see the pink, you should really be doing what we call an indirect pulp cap with either dical calcium hydroxide or MTA or biodentine. So here's an example of a uncomplicated crown fracture where the fragment was found, the fragment was brought in, the patient would have that usually in milk. That's what they put it in if you go through the tooth app. So as long as it's hydrated, and if it's not hydrated, you hydrate it while you're talking to the patient, taking a history, doing your fact finding and your diagnosis. Then the next step is to put a chamfer once you bond the fragment on, and a bevel or chamfer prep means that you strengthen that fracture line. So it's been proven that's more effective than just bonding the fragment on. And also with time, there's less chance of you being able to see the discoloration of the fracture line if you put that composite or thin flowable over the top. With complicated crown fractures, this is where a lot of dentists can get it wrong or mess things up. Whenever you see bleeding pulp, you have a chance, guys. Doesn't matter what age group the patient's in, you should try to preserve that pulp. So what's a successful vital pulp therapy? Will cover, the comparison between healthy and infected or inflamed pulp. And of course, you want a bacteria-tight seal. Everything you should be using a rubber dam for, obviously. That's an obvious. And so we know that the more you cut into the pulp, the healthier the pulp is. So often with these cases, dentists may be a little fickle and not remove enough of the affected pulp. So if it's an old injury and you find there's some oozing blood, you cut more into that pulp tissue because you're more likely to get less inflamed pulp and a more, what the response you want. Now, the materials of choice, calcium hydroxide, MTA, biodentine, bioceramics have been recommended. Definitely not resin bonded materials because they leak, and they leak at the very best, let alone put it over a moist environment. One of the problems I found with dical or hard-sitting calcium hydroxide is that it's hard to put where you want it. It goes everywhere, when you put it on the applicator, than actually the place where the pulp is. So I have a bias towards MTA, although it is, in my opinion, the best material in terms of histopathology, because you get normal dentine against the MTA layer. You don't have these tunnel defects that you can get with calcium hydroxide. One of the, and I always go through this because people ask, what you want is not this situation. You want what we call, I tell mums, like ketchup blood. You want it to actually ooze blood, fresh blood. And you cut into it after rubber dam isolation with a tungsten carbide burr. You don't use cotton pellets against it because that causes a cellulose response which can be inflammatory. Over the pulp, you might put a couple of drops of hypochlorite from far away. You don't pierce into it. You treat that pulp with care and it'll stop bleeding when you put hypochlorite. It'll also get rid of the bacteria. It causes a zone of necrosis. However, that necrosis is not bad. As long as you've got no bacteria, the pulp survives, and you can put your thick layer of MTA, and then you always protect that MTA with something like Vitrabond, and then you can do your etch bond and composite layer. So one of the issues with MTA, even if it's white MTA, is the discoloration, the grey discoloration that you can get. Many of these complicated crown fractures, you obviously would veneer later on and you can mask that discoloration. However, you know, there's a bit of a debate in the literature, and when you look at the literature and you look at the meta-analysis of the literature, unfortunately we don't have enough high-level evidence. We need more to prove that MTA is a better material. And at this point, even though I've got a bias, as you can tell, towards MTA, there's no significant difference between that and the usual dical, the hard-setting calcium hydroxide. So maybe with anterior teeth, if you're not very good at using MTA, at this current time, you can actually use dical, as long as the dical sits over the pulp, as I mentioned before. That should give you a good result, and significantly no different to MTA. There will be in future a zirconia oxide-based MTA, so they don't have the bismuth oxide anymore, and they've got rid of the aluminium part, so there's less discoloration potential for MTA. Biodentine does not discolor teeth any less, even though there's some literature to suggest that. Again, they can also discolor teeth. So the best material there, if you don't want to discolor the tooth, is actually back to the good old hard-setting calcium hydroxide. So let me show you a clinical case, because I'll show you lots and lots of cases from here onwards, because I think we can learn a lot from cases. This is courtesy of Dr. Muna Al-Ali, who used to work with me, Melbourne trained, and worked with me in Sydney. And it's an interesting case because you had an uncomplicated crown fracture of the 1-1, you had a complicated crown fracture of the 2-1, and when Muna saw the patient, even though they had been temporized, they weren't temporized well. You can see there's debonding of that fragment of that tooth. And so she had to remove to have a look. And with the complicated crown fracture, what you're seeing there is not much tooth at all. So when you discuss your options, the option that should definitely not be there is, with a patient that's young, removal of the tooth. If in doubt, get advice from your local endodontist, because many of us would be saying, please try to maintain the root to preserve the bone for a future implant, wherever possible. So options were put on the table. At the time, orthodontic extrusion was discussed, surgical extrusion and crown lengthening. Orthodontic extrusion is probably the only one I'm a fan of. I'm not really a fan of the other two for other reasons. I think they're a little bit too aggressive, and they don't always give you a good result. So in this case, when Muna had one look at that tooth, even with normal isolation, you know, we didn't have rubber dam, patient wasn't cooperative, you could see a very fresh bleeding pulp. So Muna did something outside the box. She cleaned everything as best as possible. She placed a thick amount of MTA, and this is a dry mix of MTA because it was bleeding pulp. Obviously, it'll set with MTA. The good thing about it is it sets with moisture. And then she cleaned out that fragment, you know, used etch and bonded things back on. So yes, over time, there was some discoloration to be expected. But what you're seeing on the left of the screen there, compared to at the time of trauma, what you're seeing there is actually apical closure. So you can see very obvious closure comparative to the root tip there. So the tooth was healthy and vital, and you just follow this tooth up. And the reality is that even if it becomes non-vital, you need to do endodontic therapy. Most likely by then the patient's older, so you're buying some time. The root's thicker, because obviously the tooth pulp is vital, and you might be able to do the standard endodontic therapy, and probably the subgingival equal crestal margins become supragingival with vertical growth. How about crown root fractures? So these are slightly more difficult to treat. Another case of a crown root fracture is this one here in an adult, where, you know, the fragment is removed, the pulpotomy, MTA is done, and we do ortho extrusion. Within a few weeks to less than 6 months, you'll have the tooth in the right position to be able to restore with composite. So I much rather have that in my mouth than have a dental implant. So I'll always opt for a MTA pulpotomy in this case, and then an extrusion. Here's a case where it's a 16-year-old patient who had a motor vehicle accident. It was a severe accident whereby 5 teeth in the mouth, 2 lowers and 3 uppers, were fractured, and there were catastrophic fractures in the upper region especially. So we had a combined case with a prosthodontist and an orthodontist, and we had a discussion, a decision with the patient, of course, and the parents consenting to it, is to save these teeth, because the age of 16 is a bit too early for implants, as you know, and so we need to buy a bit of time in case these things fail. So I did endodontic therapy, of course, and it was an insurance case. So obviously, insurers okayed everything with reason. Subgingival, cementum, equicrestal fracture. So I did the treatment. I placed a composite material or Luxacor materials, so that then Dr. Tarif, who was the orthodontist, could devise these mini sort of implants, and then these TADs, and then devised a device to be able to extrude these teeth. And so the extrusion was done within 3 to 6 months. And Dr. Ben Lee, the prosthodontist, did some temporization and some permanent crowns. In hindsight, possibly, for example, the 2-4 there could have been extruded a bit more, and maybe things happened a lot quicker. But it's a fairly good option, and probably the only good option for this patient who's young, whereby, implants are not indicated. How about root fractures? This is one of the areas where a lot of dentists can get it wrong, and even specialists. So you'd see root fractures like this, where the teeth are extracted, whereby all you have to do is follow them up and things heal. There's no need for any treatment at all, as long as it's stabilizing the tooth with a splint. And only about 25% or so of fractures, 23% according to the literature, actually need treatment. So here's a case where all we did is splint. Obviously the teeth on adjacent, those laterals had endodontic therapy, but these centrals didn't need any treatment at all. And what you're seeing here, once we follow up, we splint for about 4 weeks, and we follow up at about 6 months, you can see hard tissue, and that's the best healing with hard tissue at the separated fracture line. That brings me on to splinting. So I like to touch on splinting. The splint that I use these days is the titanium splint. I've got a personal preference. It's a very clean splint, and it gives you enough room to nice and clean way to put your flowable composite in between. And of course, you want to make sure whatever splint you put in, the patient's hygiene can cope with it. They can use pixters between it, for example. And it's another standard one is using 0.1 or less than a 0.16 stainless steel wire, because NITO has memory. It can move the tooth, and bonded with flowable composite. Another one is fishing line, and they talk about 16-pound or less heavy fish. So you can use that, and you can put your flowable. I don't recommend the composite splints, because as with this case, and you always put a wax so that it keeps the teeth stable, and then you bond things on. But as with this case here, the reason why I don't recommend a composite splint is because they can fracture quite easily, and sometimes the patient can't clean around them, so that, especially the younger patient, they might have a lot of bleeding and a lot of as a result, soft deposit trap and periodontal problems around them. So my recommendation is obviously one of the other 3 splints. Splinting time-wise, again, these are guidelines, because you've got to use your judgment. For example, in extrusive luxation injuries, they say 2 weeks, but you might go to 4 weeks if the tooth is still loose, or even in avulsion injuries. So the recommended guidelines are there in the, and you can find them from the IDT website. And for example, in an alveolar fracture, these days still semi-rigid is recommended. Follow-up periods are, again, a guideline. You might want to follow up more or less, but the guidelines are more follow-ups in the first 6 months, and then less follow-up at the year, and then every year after. And the other thing about timelines, root fractures that are in the middle third or apical third are 4 weeks, but if they're cervical, those are the ones where you can even go up to about 4 months and leave them splinted. Again, use your logic when you do the splinting, and cross-check with your app or with the guidelines. Now, one very important point I like to make, the take-home message really from this lecture that I like you to keep, is whenever you get a root fracture, what you would realize is that that fractured piece is actually stuck within the alveolar bone. So what you need to do is to move the tooth carefully out, and you usually grab the tooth with your finger, but if you don't think you're strong enough, you can use gauze and a forceps, extraction forceps. You move the tooth down slightly, and it then clicks back into position. And within the first 24 hours, I found many of these would click. You'll hear the click noise where they go back into position, as long as you move them down slightly and then move them in, not try to push the fragment against the alveolus. It's stuck in the alveolus. Importance of follow-ups. This paper was a very good read. I recommend you guys find it and read it, but again, courtesy of Dr. Shergerson. And what Dr. Askia found was, you know, a case like this, you know, a lot of people would extract then or at 9 months. And this is an example of a case where you're finding internal, again, you know, resorptive area. It's similar to transient apical breakdown that Jeffrey Heatherstone discussed at the apical point. It's in where the fracture line is. So again, if you don't have a lesion or breakdown adjacent to the fracture line, it's within the root, that's a good sign, because 5 years later, no treatment, tooth survived with normal sensibility testing, and there was no need to do any treatment, or even worse, extract that tooth. So here's a case where you see the opposite. You see a fracture line and you see a lesion, and you also get symptoms. So the patient had pain, slight swelling there, tenderness to palpation, and it was non-responsive. So I went treatment with MTA to the fracture line. Then I placed an orifice plug, usually a Fuji 9 base, and then cavity and GIC. And you can see 2 years later it's been very stable, and healing with hard tissue mainly, and a little bit of maybe soft tissue at the fracture line. Worst thing you could do whenever you have you want to do treatment because the patient has symptoms and there's a lesion, is to actually go through the fracture line and treat the apical portion, because by then you push the apical portion out, you create a space, and that could be encouraging more bacteria. So remember, the apical portion is sterile and doesn't need treatment. It's often the coronal portion that needs treatment. Here's a case where, when you have a look, this was the pediatric dentist who referred this. They did a beautiful titanium splint, and they referred because there was a high up horizontal fracture. If you have a careful look at this cone beam, you can see the fracture is really high up. There's not much we can do with that root, okay? So in a case like this, you got a few options, because the patient's you know, only about 9 years of age. I wouldn't close the space, not in that case. And the reason for it, I also discussed this with the prosthodontist, is that the mesiodistal you know, proportion of that tooth, that lateral there on the left, which on the right, which you're keeping, it's much smaller in length than the canine mesiodistal. And to bring that, remove that and bring the canine in and reshape it, you've got to drill a lot of tooth. So I'm not a fan of that, and you can often get black triangles. So another option we considered was root submergence. So what we did there is we cleaned out the root fragment, we removed the coronal portion. The patient was going to have early interceptive orthodontics anyway because of the overjet being severe. And so what we did is we kept the root fragment below the crestal bone, and we just sutured things back over the top. And that root would keep the alveolar crest height, so that following, you know, orthodontics and having maybe a permanent retainer there with a pontic, the patient, when the right age, could have implant replacement. Now, the final part of this lecture is talking about injuries to the periodontal tissues, and I would like to cover concussion injuries. With concussion injuries, you really don't need to do much. There's no real loosening. There's a little bit of maybe slight, sometimes movement. There's no displacement, certainly. So all you do is put the patient on a soft diet, reassure them. You don't need to really splint those teeth, and you can follow them up with baseline pulp tests to make sure that nothing changes, and hardly ever do the teeth with a concussion injury need any further treatment. Subluxation injuries, this is teeth that have underwent loosening, and this is without any clinical radiographic displacement, but are slightly loose. If they're very loose, or if because of emotional reasons for the patient, you might splint them, but otherwise most of them don't need any splinting. Again, the same sort of instructions, soft diet, and we just do regular follow-up, and most likely those teeth will remain healthy. The pulps will remain vital. And if there is a radiographic displacement, this is where it gets a little bit more tricky. And we have a look at an example here where there's been a radiographic displacement. The dentist didn't put the tooth back in, or wasn't strong enough at the time, because it was maybe more than 24 hours and the blood clot formed. So again, I recommend picking up extraction forceps carefully if you don't have the strength, making sure the patient's numb, and putting a gauze over it and pushing the tooth and clicking the tooth back into position. Because then after 6 weeks, it's a lot harder to manage that case, and the patient obviously needs orthodontics and wasn't very happy. So again, another hint, same hint with the root fractures, same sort of thing. If you can't push the tooth back in, it's probably because you haven't pushed the tooth down, because often then it'll click back into position. So remember that alveolus, you know, there, and the root being there and being stuck between the alveolar ridge there. And this is a very severe extrusive luxation injury whereby I didn't do something right. I put everything back in, but I failed to review the patient early enough, and that was due to, patient not being able to come in, and it was actually very obvious within 6 weeks bacterial inflammatory resorption that can happen very quickly and can destroy teeth. So recommendation guidelines are commence RCT when there's a severe extrusive luxation or any type of luxation injury that's severe within the first 2 weeks. Okay, so do not leave it for more than 2 weeks, because obviously at 6 weeks there was inflammatory bacterial resorption, which can be quite nasty and can eat the tooth away really quickly. Intrusive luxation injuries are one of the worst injuries. So I recommend you refer, because often it's a multidisciplinary management. With young teeth, and maybe even, teeth that are deciduous, which we're not covering here, we're covering adult teeth, spontaneous re-eruption is possible, but with adult teeth, and there's an example of a spontaneous re-eruption, but with adult teeth of less than 6mm intrusion, what you really need to do is to ortho extrude so that within a few weeks you can get in and extirpate. As I showed you, if you don't, you've got a higher risk of inflammatory resorption and a higher risk of replacement resorption. So you've got to get in and extirpate and medicate the tooth. So therefore, the orthodontists I've seen amazingly be able to move something like that within 3 or 4 weeks of the injury, or even sooner. If it's more than 6mm, this is where the orthodontist might say, well, look, it's a long way and it won't, come out within the 2, 3, 4 weeks, which is relatively safe. Therefore, you might want to do surgical repositioning and bring it back into position. My final part of the lecture is to discuss a few cases of avulsion injuries. Now, avulsion injury, central incisors is the most common. They're often the most mismanaged ones, where they need long-term management and multiple specialists involved. Here's an avulsion injury, AFL, and you can see 2 teeth being avulsed. It's either Photoshop or it's real. And this is where you really want an avulsion injury, because that was a deciduous tooth. So very important point is emergency management is when they call, when the patient calls, when the mum calls, when the teacher at school calls, you tell them immediately replant. Okay, wherever possible, if they can, they grab the tooth by the crown and they place it in, even if it's not, mesiodistally in the right position or palatal buccally, it's better than putting it in milk. And again, if they're stressed out, you tell them to download an app. But even quicker over the phone, the doctor can actually instruct them. Milk is a very good substitute, obviously, because it keeps the cells viable and it's easily accessible to most people. And so again, there's a comparison between what type of milk. It doesn't matter. As long as they put it in milk, you've got a bit of time to buy. So I like to cover the avulsion injuries with mature teeth, less than 60-minute dry time, and more than 60-minute, and of course we'll cover immature teeth as well. So let's cover the dry time less than 60-minute. So you'll obviously replant and you'll do nothing to the ligament, because there's a chance less than 60 minutes, especially in the 30 to 45-minute period. After 45 minutes, it's a bit iffy. According to the literature, there's a huge drop in success rate of the periodontal ligament cells. You like to preserve the periodontal ligament cells, so you just clean the tooth as best as you can. You can wash it with Emdogain if you have it, or just make sure it's a clean surface and you place it into the socket. And immediately, if you like, if you've splinted and if you've got time, you can use a steroid paste, odonto paste or Litamix. I'm not going to compare them, but I would prefer, if it's an anterior avulsion injury, which is most often anterior, I'd use odonto paste as less risk of it discoloring. And you can immediately place that anti-inflammatory paste. You don't want to place calcium hydroxide immediately, because that's not very friendly to the cells. It can kill cells and it can cause more inflammation. So you'd wait 7 to 14 days and you get them back if you prefer to use calcium hydroxide and you don't have access to odonto paste or Litamix. Now, it's important with immature teeth that you don't do that step. So the only difference is if it's less than 60-minute extraoral dry time, you put the tooth back in, as long as the ligament's clean and you got it back in the right position, but you don't extirpate the pulp, because we know that in about 18 to 25% of cases, especially in the first 45 minutes, there's actually normal root development and the pulp survives. So here's an example of a tooth which was avulsed and was immediately within half an hour put back into socket. So this tooth 4-1 here we're looking at here. And once I followed up, about 5 months, the tooth was vital and it was actually undergoing normal root development. So again, another example is when the poor dentist is being instructed to remove a tooth. Instead of removing the deciduous tooth, they misunderstood, they removed the permanent premolar. So when they rang me, I said, please splint, as they did correctly here, and they replanted that tooth within the first half hour. And you can see 5 months later, the tooth is actually normally responsive, is undergoing normal root development. Now, what about if you've got an immature root and you want to promote it? You want to promote the ligament and you want to promote revascularization. So there's some literature, quite a bit of literature on minocycline, and you can get Arrestin. That's a product that you can get with minocycline, which periodontists use, Arrestin. And you can actually dip the ligament into that, or Emdogain, because Emdogain is also readily available. And the initial research is quite promising that that can preserve the ligament and reduce the risk of and replacement resorption. Emdogain is a little bit controversial, but definitely minocycline is what I highly recommend, which you can get and you can keep in somewhere safe and use it in case you've got an open apex avulsion injury, because the success rate being 25% for revascularization with injuries that are less than 60 minutes open apices becomes all of a sudden 40-50% using that. Now, if it's more than 60 minutes and you've got a mature tooth, and in this case also immature teeth will be very similar. If you've got a more than a 60-minute dry time, your cells are going to die. If you don't remove the cells using an acid or sodium hypochlorite even, because that dissolves away the tissue, and the fluoride part is controversial, it's not highly recommended, so that's why I put asterisks, but some people use fluoride to delay replacement resorption. So you're guaranteed the cells are not going to survive. So therefore, in those cases, you have to scrape the cells off so you don't end up with a severe inflammatory bacterial-based resorption because there's dead necrotic tissue around those cells. And that means that once they're in the socket, you could end up with more periodontal problems as well. And so you scrape the cells away, the ligament, and you place it, you splint, and then after splinting, you'd be expecting ankylosing, you're expecting replacement resorption, which you can manage down the track. A really good case of Dr. Neska Kohenka's, which I want to share with you guys, is a real true, you're not going to be able to get ethics approval to do this. You can do it possibly in monkeys or rats, but you're not going to be able to do it in humans. But this is a real good trauma case where what happened, the story is there were 2 avulsion injuries, and when they called the dentist, Dr. Kohenka, over the phone told them, please replant the tooth that you found. And so they replanted tooth 2-1 in 1-1 site. This is the parents. They couldn't find the other tooth. For about 3 hours later, they found it eventually. And so when they saw Dr. Kohenka, removed that. I probably wouldn't do step. Removed the 2-1, placed it in the 2-1 socket. I'll probably leave it in that socket, even if it's in the wrong position. And then 2 or 3 hours later, the tooth was found and he replanted the other tooth. And of course, the 1-1 being the one which had more than 60-minute extraoral dry time, it had extirpation. And for some reason, Dr. Nesta Kohenka decided to place MTA and obturate. I would have probably left it with a long-term dressing. When you follow this tooth up, you're expecting replacement resorption, and this is actually invasive cervical resorption as well. And if you notice the tooth 2-1, which was within half an hour replanted by the parents, you get calcified tissue formation. Calcification is a very good sign that the pulp has survived, and it means that this tooth is going to last the distance. And of course, there was infraocclusion there. Another case of multiple injuries, one of the largest cases I saw in Melbourne in the hospital setting when I was training, because we did a lot of emergency services. So this particular patient was a librarian walking down the stairs of a library, and as they fell down the stairs, every time they hit their chin, there was a different trauma. And so at about 3 p.m. there was an avulsion injury. Now, she was well read. She actually placed the tooth under her tongue. So when I saw her and we did a PA mandible, she gave me the tooth under the tongue. She put her tongue out and I picked up the tooth. And immediately, after finding out there was no other neurological signs and there's no other major fractures, I went for replanting that avulsed tooth. So I tried my best. It was almost like a jigsaw puzzle because there was a crushing alveolar injury. and I tried to keep things stable with a wax, and I splinted. And in the lower region, there was a severe extrusive luxation injury. There were also, the teeth had gone through the lower lip right through and through, and the lower teeth had gone through the upper lip. So I did lip radiographs. This is 25% normal exposure, as I said, and there were no fragments. And so I removed all the minor salivary glands, and I sutured everything back up as best as I could with 3-0 catgut and 5-0 sutures. That was the best I could get. If I could find finer ones like plastic surgeons, I would have used it. So we didn't make the mistake I made before. I learned from my mistakes. First of all, I did the best I could. That's what we had in emergency services. So, I used that. It's a non-nitrile wire, and I splinted. Things were developing nicely, but I remembered something, and I learned from my mistakes that I should get in within the first 2 weeks and extirpate those extrusive luxation injuries and extirpate or clean out the previously root-filled tooth, which was the 2-1, and place calcium hydroxide. So that's what I did, which reduces risk of bacterial inflammatory resorption. Final case is an interdisciplinary case, and why I like to share this is because it was an interesting case and it was involving other specialists. So I support the rugby team, Sydney Uni rugby team. So they've got Gentle Endodontics logo on them, and they go play, and I support them because I want them to win against med school mainly, and every 10 times we might win once. So about Friday night, 9:30 p.m, after we won the trophy against med school, because usually they're the rivals, the main rivals, I'd obviously on the rugby field, everyone's wearing a mouth guard, but he was the captain, a very important halfback, which I needed on the field. But because we were winning, and I noticed there's a neurological sign, he was like, I'm okay, I can go back on the field, but he wasn't quite. He was semi-unconscious. We kept him off the field, but within the same time, around 9:30, and I apologize for the wording here, the student doesn't mind me sharing this. Anyway, he sent me a text message saying, mate, I was coming to the game. He's the tallest, 2.1 meter Asian you'll find, and he was one of the forwards. Most of the other dentistry group are pretty small in stature. So anyway, he was a very important forward, but I asked him, why didn't you attend? And he said, look, this is what happened. I was cycling with my girlfriend to the game, and I fell off my bicycle. And this is the sort of injuries we saw. So on Saturday, we opened the clinic, and we see the patient, obviously, and on the Friday night, the students in the hospital at Westmead did some dentistry, splinting with GIC, I guess, or composite. And, there was some complicated crown fractures. There were some uncomplicated crown fractures. And you can see the extent of those injuries when we did a cone beam, quite severe. And that's what it looked like. And we did the lip, sort of imaging. There was no real anything in there because the students hadn't done any radiography. And here they'd done a really nice splint, okay, the best they could, but they didn't take the radiograph because the radiography department was closed. And that's what was seen. So you can see that root gone right through, and this is a very high up fracture. So, obviously I couldn't do much, but to, medicate the upper teeth because they were, at the time, catastrophic fractures that involved the pulp. And, the endodontic therapy of the upper teeth was done. These are all closed apices. And we followed things up. With the lower case where there was a severe fracture and the root had gone, the tooth was carefully removed. And the periodontist had done that. And then the orthodontist is using Invisalign here to close the space. That was the best option for this patient who had previous orthodontic therapy as well. And so, fairly good result, but the periodontist had done some treatment there because while everything was being closed, there was ongoing soft tissue and hard deposits had developed for the student. So you can sort of see a little bit of a periodontal ligament widening there. And, about 3.2 years later, things are good. There's a bit of a pocket there where patients got good oral hygiene. It's not really an issue, the periodontist tells me. And the prosthodontist is fairly happy with the work that's been done and the patient's very happy. So I'd like to conclude by making these final remarks. Guidelines are very important, so download the app or go to the guidelines so that it makes your job a lot easier. And, timeliness of treatment is at most important. Added to that, baseline testing and follow-ups, regular follow-ups are important, especially initial trauma. You need to follow them up regularly. And the aim is to preserve the pulp wherever you can. Pulp is resilient, as I showed you in many of those cases. You can do MTA pulpotomies and keep them, or the pulp space, or at least the root, especially in the young immature teeth or the young adult, where the implant option or other options are not a very good option. And the final remark is, in traumatic dental injuries, especially the more severe ones, a multidisciplinary treatment plan is important for short and long-term survival of those teeth. And again, never hurt to get a assessment done by an endodontist and other specialists, and ask a question at least, and then you can manage them accordingly with them. Thank you. Any questions, please feel free to email me at gentlendodontics, mehdi@gentlendodontics.com.au, and I'm happy to respond, or Facebook me. I'm on Facebook, so private message me if you have any questions regarding anything I covered.